So I think, especially from cervical screening, is your HIV positive patients, ask them, do they know what a cervix is? Have they had screening? Because they really should be encouraged. So in fact, the guideline says at diagnosis, they should have a cervical smear. HPV testing becomes really a problem in HIV positive patients because they often have many HPV types. So, you know, that's why you HPV screen and then you triage back to pap smear. But really, and I bet you, look how many women, ask them when they all had their pap smears. Okay? So it's not only our patients, it's also about us. And from an ovarian cancer perspective at the moment, we've just got a new trial. We got $1 million in genetics to look at Black women's ovarian cancer, because we believe that that genetically it's probably much higher than we think, because there's PARP inhibitors now that could be used. So I'm not here about cancer, I'm here about contraception. So contraception is very close to mine and to Alna's heart. You know, unfortunately, contraceptive clinics are not open after hours, which is a big problem. Most women work. Remember, women, we are the foundation of society. We're mothers, we're workers, we're everything. And to go and take a whole day in a contraceptive clinic is a problem, because often we need a letter for work, we don't earn money, etc. So I think all contraceptive clinics should be open after 4 o'clock, close at midnight, and then on weekends, and then not during the week. And also for school kids. When do school kids go for contraception? Okay, so forward, back. Up, down, that way. Okay. So first of all, I can't spell. If there's spelling mistakes, I'm sorry. I have lots of disclosures. I've done many things legal for cash. And then to start on unintended pregnancies. You know, it's quite interesting that in South Africa, nearly 65% of pregnancies are unintended. They were not so-called planned for. So that's quite high, and 36% of them ended in termination of pregnancy. And one of the biggest problems is adolescent pregnancies. The association, obviously, of sexual violence, of unintended pregnancies, particularly in adolescents. And obviously, this group of women are neglected, and they really have a high cost to the health burden. So we really need to think about adolescents and how we approach contraception. If you look year on year, our number of terminations of pregnancies are increasing. And thank God we have liberal laws in our country, not like the US, that is led by a bunch of males, okay, who do not fall pregnant and don't have babies. So, you know, we empower women, and women do have the ability to choose termination of pregnancy, but that should be followed by adequate contraception. That's what is key. You know, we should not be using termination as contraceptive because we don't have access to contraception. So that is very important.
Okay, sorry for everyone online. We're back at it.
But I need to.
But you're not. Sorry. Told you teething problems. There we go. And you're back.
And I'm back. Okay. So when you ask women about what they know about.
Not all the way back. Sorry, everyone. We are trying. Let's just see. Zoom meeting. Share screen. Okay, now we're back. Yes.
So if you ask women about contraceptives that they know, most women know about injectable contraception. Look how few know about vasectomies. Very few know about vasectomies, and very few people know about emergency contraception. And that's another thing we need to educate women, that you can have emergency contraception, but the problem is access to that emergency contraception. You pay for it privately, it's not available in the government sector, and you have to go to a pharmacy and you have to speak to somebody and say, I had a hoopsie last night, I need an emergency contraceptive. And then you're like, shying away. We need to make it easy for women to access emergency contraception. So look at this in the private sector. So 62% of women have an oral contraceptive in the private sector. Injectables, this didn't come out very well, but injectables are much lower, as are IUCDs, but IUCDs are much lower even in the government sector. So adolescents in 2020, I don't know if you saw the statistics, 23,000 babies were born to girls under the age of 18 in Gauteng, of which 934 were born to girls under the age of 14. And this is during the pandemic, when they didn't go to clinics, they didn't get their contraception, and it was 60% higher than in the previous years. In the Western Cape, 79% of sexually active girls are not using any form of contraception. Nothing. And I told you how few are using condoms. So, no. Okay, so girls should be carrying condoms. They should be saying, no sock, no. Do you understand? That's what should be happening. Really, we should be educating our adolescents. I told my son, if it doesn't get a sock, it doesn't go anywhere. I told my daughter, if it doesn't have one, it doesn't go anywhere. We should be telling our children this. We must be educating them. So you have to consider various things in adolescence. Remember, in South Africa, you may not refuse contraception to a 12-year-old. If they come into your rooms, they want contraception, you do not need parental consent, and you may not refuse contraception to them. And you have to take into consideration physical development, cognitive development, emotional, and the moral development. Your moral judgment has nothing to do with it, okay? It has absolutely nothing to do with it. You need to make sure that adolescent is safe, not being coerced into sexual intercourse, is not being used as by the blesser. You has to be safe, that situation, but you need to give them contraception. You can't say, no, sorry for you, you're too small, you mustn't be having sex, because at the end of the day, you want to make it safe for them. So you need to have decision-making together with them in a safe environment, and always encourage them to use condoms. So you have to think about a LARC. What is a LARC? A LARC is long-acting reversible contraceptive. So this was a fantastic project that was done in the UK. If you take time and you educate somebody about all the various forms of contraception that is available, 70% of participants chose a long-acting reversible contraceptive. And 69% of those were aged 14 to 17, preferred a LARC, a long-acting reversible. So the advantage was that it does not rely on user adherence. And if they discontinue a LARC, they have to find something else. They have to come to you to remove the loop, and then you will give them something else. So that is the advantage of using something like that in an adolescent. It also gives you longer visits. I told you, that they don't have to come back so often, and it's discreet. You can hide it from your mother if it's in your cookie. Do you understand? But when your pills are lying around, then somebody's going to find them, and then you forget them. So the contraceptives to consider in an adolescent, it is old-fashioned, old-fashioned. intrauterine contraceptive devices can be used in adolescence. Okay, you do not have to have had a baby. You do not have to even had sex to have one. You can have an IUD inserted if you're considering intercourse. So you can use a copper IUCD. Remember that you need to be wary because it causes heavier, longer periods. You can use a Mirena. It's an excellent choice for a young girl who's having heavy menstrual bleeding, or a Kylena, which is a smaller progesterone-containing intrauterine contraceptive device. A Nuvo ring is a ring that you fit in the vagina for 3 weeks. Did you even know it existed? So it's a ring you put in for 3 weeks, you take out for a week to have a period. If you don't want a period, you just put another ring in. It's a soft little thing, you have sex with it, it's no problem. Sometimes it causes a little bit of an increased discharge, and young girls don't like that. And then obviously there's the Implanon. And the Implanon, obviously, you insert in the arm. It's also discreet. You have to go to somebody to take it out and get another contraceptive if you don't like it. I want to say a word or two about Depo-Provera. And why I want to say something about Depo-Provera is we often use it in that adolescent group. And the maximum time you're going to get a talk on osteoporosis when you lay down bone is in your adolescence. And the time you start losing bone is in your perimenopausal, menopausal phase. And in fact, we should really be cautious about the use of Depo-Provera in adolescents and perimenopausal women because of the bone effects. And Depo-Provera actually causes amenorrhea, which is great, but your return to fertility takes about a year, and many women don't like that. But be wary of the bone problems with Depo-Provera. So the pill, the oral contraceptive pill. Do you know the average adolescent misses 2.7 pills per pack? Not very good, is it? Not very safe. So the discontinuation rates are about 50%, and it's usually because of the home environment. Where do you put your pills? How do you hide them? How do you remember? So if you get buy-in with the parent, I say to the adolescent, you attach your pill to your toothbrush or to your deodorant, because that's what most people do every day, is they brush their teeth, most people, and or put on some deodorant of some form. If you put an elastic band with your pill onto the toothbrush, take my pill, brush my teeth, then I don't forget. But when it's in the panty drawer, in the handbag, in the school bag, whatever, they forget. So there are health benefits to the pill. First of all, it decreases dysmenorrhea and iron deficiency anemia. You know, iron deficiency anemia decreases your IQ, decreases concentration, and is associated with depression. It is underdiagnosed and undermanaged. And so the oral contraceptive certainly, and so does the Mirena and the Kylena, decrease iron deficiency anemia. Obviously, it's important in the management of polycystic disease, endometriosis, acne, and premenstrual dysphoric, when you go crazy before the period. You want to kill everybody, the oral contraceptive. So which ones to use? So it's an effective method if you take it properly. The 24-4 pill has a higher pill index than the 21-7. So your packs have 21 pills and then 7 placebos. That's the Nordet, Trifazole, or the old ones. The newer pills have 24 pills and 4 placebos. And there's a new one called Zoli. Zoli has a very progestogenic progestogen. I shouldn't tell you this, but in fact, if you missed it for 2 days, you're probably still safe. And that's why it's a good pill to use in adolescents, because they are more often than not going to forget their pill. The other thing with the new estradiol-containing pills is that they can cause amenorrhea and they make your periods much lighter. In fact, nearly 40% of young girls or women who take Zoli don't have periods at all, and then they get very nervous, and you just have to reassure them that it's fine. The pill was made by a man for women who thought we liked periods. Okay, there is no reason to have a period at all while you're on the pill. The blood doesn't get trapped, you don't go mad, none of those things. In fact, in Europe, there are no placebos on your pills. And in the US, there are tri-packs. There are 3 months of pill that you get. So you don't ever have to have a period. In fact, there's a guy, William Bart, he says you take the pill continuously. When you have a breakthrough bleed, you skip 7 days and then you go again. So the period is not necessary. Okay, emergency contraception. 4% of teenagers used it more than once in a year. That's when you go to the pharmacy, emergency contraception, please. How many times have you used it? Do you not think you should be using something more permanent? Okay, that's what the discussion should be. And basically, you use 1.5 milligrams of levonorgestrel. It's well tolerated. It gives less vomiting than, remember, in the old days, you used to have 2 Overall-Statin, 2 Overall in 24 hours could make you vomit. But availability is the problem. The other group of women is the older women. Don't forget the older women. So women think they're not going to have babies. In fact, 1% of 50-year-olds had Cooksie pregnancies. Your ability to fall pregnant is less, maybe because you're getting less nookie than a young person, I don't know. But you do need reliable contraception. And often in older women, we forget about that. And that's important. We need to avoid these unintended pregnancies. So this woman was 60, she had twins, she was an Italian psychologist. Unfortunately, she died of breast cancer and left her twins motherless at the age of 4. So the WHO criteria tells you which contraceptive you can use in which person. And in fact, there's an app for everything, but there's an app with the WHO, and that's an important, easy app that you can use to tell you whether you can use that contraceptive. In a premenopausal woman, if you use a combined oral contraceptive, it will reduce their hot flushes. You'll know when you get there. It maintains bone strength because it has estrogen. But you have to be, and there's a risk reduction in ovarian, endometrial, and possibly colorectal cancer if you use a combined oral contraceptive. But remember, most older women are overweight, diabetic, hypertensive with other comorbidities. So you have to take that into consideration when you're considering a contraceptive. So if you are going to use a combined oral contraceptive in these women, then you would rather use a lower dose pill, or you would use an estradiol containing pill. So there's only 2 of those that are available. They're not available in the government sector yet. They are called Zoli and Clara. In the government sector, we only have ethanol estradiol containing pills. But it's an excellent solution because it will give you bone health, it will stop your hot flushes, and it will control your periods. But make sure there are no medical comorbidities for those women. When do you stop the pill? When do you stop contraception? So obviously when your husband's had a vasectomy, you can stop the contraception, right? Otherwise you stop at 50, and you must say you must use an alternative, because we don't know if you are menopausal yet. Your menopause can only be at 55. So if you stop an oral contraceptive, you need to tell them to use a condom at least for 6 weeks to see if the period comes back. If the period comes back, they need to go back onto the contraception. But remember, as soon as you stop a pill for a month and you go back onto the pill, you increase your clotting risk. So you must never stop a pill and wait a month and restart. If you're going to switch pills, you switch at the same time, because you don't want to increase your clotting risk. Progestogen-only pills, classically they're used in women over the age of 40. There's a small window of when you take your pill. You know, if you take your pill at 6 every morning, you should be taking it at 6. You've only got 3 hours to remember your pill in order to be safe. We don't have any high-dose progestogen oral contraceptives in South Africa as yet, but they do cause depression. Depression is a problem. So is PMS in women who use progestogen-only contraceptives. So remember that. And in the perimenopausal woman, and menopause, that's when you go a bit sugar, and your risk of depression is much higher in that time period because of that transition as you transition into the menopause. Obesity, big problem for all of us. What is interesting from an obesity perspective is that contraceptive trials exclude overweight women. And obese women may have other comorbidities and they have a DVT risk. So the oral contraceptive is a very real problem from a VTE risk, but it's classed as a category 3 in women 35 to 39 kgs. But we have no data that it actually works in an obese woman. You know, why do we give one dose for everybody? The 40 kg woman and the 90 kg woman, does it work the same? We don't really know, actually. That's the truth. The only thing that we know is that there's increased absorption of contraceptive steroids by adipose tissue. We get an increase in circulating volume, so we don't really know if they are that effective. The only thing contraceptive that has been trialed in an obese woman is the Implanon. So the problem with putting a loop in an obese woman is that visualizing the cervix can be a problem. You know, if you've got a grande lady, it's like looking for the cervix to put the loop in can be an issue. And the vaginal walls fall back. So you have to use a condom on your speculum to try and hold the vaginal walls away in order to put the loop in. So technically it can be difficult, but you use an ultrasound to guide you to insert it. But it's a great contraceptive because it transitions you into the menopause, and then you don't have to worry about stopping the pill and when you need to change over the contraceptive. The Mirena is great because it prevents endometrial hyperplasia, particularly in the obese woman, because they're at risk of endometrial cancer. And you can also use it in the perimenopausal woman as your form of progesterone in your uterus, and then you give transdermal estrogen for your hot flushes. But we have no data on breast cancer for Mirenas. We have depression, you get dysphoria, you get breast pain, you get acne, and you get headaches. And ovarian cysts are a problem with the Mirena. So it has its own issues as well. And then lastly, I just want to say a little bit about postpartum contraception. COVID-19 had a big negative impact on sexual and reproductive health. Pfizer made a lot of contraceptives. They're like out the door with the contraceptives. We on the jab making all our money. So contraceptives were in short supply. And that is a big issue. I don't know if any of you are on a contraceptive, you go to the chemist, you get this one, it's not available, that one's not available, that one's not. So most hormone drugs, hormone replacement and contraception has been in short supply and is still in short supply. So contraception is a big problem for us in terms of the COVID-19 pandemic. And the issues were stock outages, even copper IUCDs and implants, etc., have been out of stock because of the COVID-19 pandemic. And obviously women didn't go and get their contraceptives over that time. So postpartum contraceptive devices, for me, is a big option. So it's the most time that women have access to healthcare because they deliver their baby. And then soon after delivery of your baby, we know that if you increase your time span from baby to baby, is that those children do better, etc. Health-wise, you do better. Is you can put in a loop straight at delivery, either at Caesar or post-delivery immediately. Within 2 days, you put in a copper IUCD or even a Mirena at that time. Your expulsion rate is slightly higher. You wait until obviously the placenta's out. Yeah. And then you put it in. You should put it in within the first 2 days. If you don't, you have to wait until after 6 weeks. But they're not coming back. This is the time. You got them. Captive audience, put in the loop. Okay. There's a 10 to 15% expulsion rate, lower if it's immediately post-delivery than early postpartum. Expulsion occurs within the first 3 months, so you ask them to feel the strings. But I think that's the time we also need to be addressing contraception. So the adolescence and the post-delivery. And so every patient that you see with a medical problem, how's your contraception? Have you sorted your contraception? Have you heard about contraception? Do you know where to go to get contraception? That's what you should be discussing with them.